but I'll try and distinguish the things that are care for today versus things that we think of as cures for tomorrow. So as we're going through, we'll be talking about the field of genetics and genomics and hopefully try and demystify some of the things about who to send for genetic testing, some of the pragmatics about how to interpret the genetic test results, and then ultimately how we're using this information in management. And I'll try and focus this on conditions related to the brain and behavior, realizing that there's still work to be done in terms of understanding all the genetic basis for this. And some of it is straightforward, some of it is more complicated. And so, again, I'll try and help you understand where we're going in terms of some of the research to understand the more complicated issues specifically. So I'll use autism as a use case, but for those of you who may study other things like ADHD or other behavioral conditions or epilepsy, muscular dystrophies, really many things within neurology fit within this. But what I mean by this is when you think about whatever that condition is, I'll use autism again as an example, is something even genetic? Should you even worry about looking for a genetic diagnosis? And how do you make that decision if this patient with this diagnosis warrants any sort of genetic evaluation? So the first thing that we oftentimes do from a research point of view to understand the heritability or how genetic a condition is to be able to understand identical twins. And the thinking behind this is the following. Identical twins obviously are almost always genetically identical. There are interesting cases in which there are small genetic differences between identical twins, and I could give you a whole talk about that, but I won't today. But we consider them identical. They also share the same intrauterine environment, and many of them share the same postnatal environment. And so if something is genetic, given also many sort of controlling for the environment as well, one would expect that concordance to be nearly 100%. And so if you consider, and again, this is not primarily a neurological condition, but something like sickle cell anemia, for instance, if one twin has sickle cell, the other twin almost always has sickle cell disease as well. That is obviously a monogenic or a single gene condition. And again, the concordance being about 100%. The important thing to note here is that for autism, even in identical twins, that concordance is not 100%. So to appreciate that this is not all genetic, and this may sound sacrilegious for me as a geneticist to say that, but I want to be clear that something like autism is not 100% genetic. One can compare that to fraternal twins. So individuals, and when we do this specifically for autism with same-sex fraternal twins, those individuals will share 50% of their genetic information, similarly to other siblings, but they have the additional control of having the same intrauterine environment and oftentimes at least much shared postnatal environment. And so the difference here is quite substantial, not surprisingly, for fraternal twins between identical twins. But importantly, to show that for siblings, again, one can restrict this to same-sex siblings, but if you look at siblings with autism, now again, the variable here is sharing 50% of the genetic features like fraternal twins, but now the difference is intrauterine and postnatal environment not as tightly controlled. You see the drop off in heritability to 20%. So my point being that if you go through the similar exercise for other conditions, one can get a sense of how much something is in terms of genetic contributions versus environmental or exposures. It obviously doesn't explain any detail about how many genes are involved, what those genes might be involved. It doesn't give that information, but it is talking about, and I'll point this out specifically, heritable information. And I'll explain the difference that I'm going to say later. But in other words, this is transmitted information from parent to child that we get when we calculate this heritability. That's in contradistinction, which I'll talk about later, which there are genetic factors that are de novo or new in the child, and there even are genetic factors that are de novo and happen after the point of fertilization, and those will look like somatic or mosaic mutations and that's when you can have the discordance between identical twins, and those are particularly difficult sometimes to identify. And in particular, and this is work that Chris Walsh has done, can be important for neurological conditions when it comes to epilepsy specifically, and oftentimes focal malformations. So within this, you'll get a sense then of how much genetics plays, how much the environment plays. And the environment, again, this doesn't specify, is this a prenatal exposure? Is it, something exposed to a medication, to an infectious disease, to something in the environment? It doesn't give any specificity about what those etiologic, like the precise exposure is, just to say the relative contributions of the two. So that's important to frame this, because if one were to come up with estimates, for instance, where this looked like identical twin, the concordance was 0, and fraternal twins, it was 0. You didn't see similarities between these, then I'd say, why are you wasting your time with genetics for that condition? That clearly is an exposure. So anyway, something in terms of framing this. Okay, so if this is a condition like autism, intellectual disabilities, epilepsy, muscular dystrophies, many of the things that you see every day, you'll come up with a calculation that says, yes, at least some portion of this is genetic, and you'll come up with a portion, and I'll just give you the kind of the bottom line, that with all the conditions that I specified, some amount of that is going to be monogenic or single genetic conditions. The reason I'm making the distinction is that some of you will appreciate there are other genetic contributions, including what has come into vogue of polygenic, in other words, many genes, and even things like polygenic risk score. I'm not going to spend too much time talking about that today, because at that level of being able to make a diagnosis or predictive testing, those things like polygenic risk scores, I'll just say bottom line, are not really prime time and ready for clinical implementation. The utility for those is really not very high right now. We are testing these in rigorous ways in research studies. So it's not that I think they might never have a role in clinical implementation, but right now it's much more on the research basis that we use them. So I'm going to focus really for the most part going forward on monogenic or single gene testing or copy number variants, which I'll get into. So the question becomes, and I have to say, I think this is a reasonable question to ask. You have a clinical diagnosis. So you have a clinical diagnosis, for instance, of autism, attention deficit disorder, intellectual disabilities, epilepsy. What does it matter in terms of having an underlying etiological basis? Why do you need to know that it's due to this gene versus that gene, tomato, tomato, potato, potato? Does it really matter? And I would say in some cases it does, and it's actually quite important. In some cases, it matters less. My prediction is that over time, it's going to matter more and more, because there are going to be treatments that are available that are specifically genetically focused. Even when we start getting to things like for spinal muscular atrophy, now 3 FDA-approved treatments, but you have to know it's actually SMA. And that's because in some cases, it's an ASO that's targeted to increase SMN, survival motor neuron protein production. It could be a genetically based therapy with a gene addition, again, specifically for SMA. And as an example, if you had an SMA look like with the gene of SMARD1, that's not going to work if you target SMN1, for instance, in terms of the treatment. So with that, it becomes important. I often find, especially in children, that parents want to know about prognosis, adults as well, but prognosis is a question. The younger the child is and the less clear the diagnosis, or the prognosis rather, the more important that is to parents. So being able to give some idea of what the future holds can be important. It also, and I would say this is more of a philosophical sort of answer, but I do find for parents especially that this can be important to just answer the why question. Why did this happen? And I will say mothers more so than fathers do carry a sense of guilt. I'm not saying they should, but in terms of why, was there something I did during the pregnancy? Was there something I did or didn't do in taking care of my newborn? But there's this guilt that they carry around. And sometimes being able to just answer that question, in some cases absolve them of that guilt, especially when it comes to many of these de novo genetic events, I find just helps them literally sleep better at night and come to peace with things. And I can't tell you exactly in terms of health economics what that is in terms of impact, but I will say in terms of quality of life and parental satisfaction, it is important for them. And then the final question, and this is true especially of parents who are still in their reproductive years and sometimes siblings of individuals who have these conditions, the question of, is this going to happen again? And is there anything that I might want to use this information for in terms of family planning becomes important. I will say very specifically, it's not that I, am advocating for abortion or termination of any of these pregnancies, but for many people, it's actually being able to give them the information that it's not likely to recur again, and to give them that sort of take that burden off of them psychologically and that anxiety to go forward and to have other children if they so choose. In some cases, for our families, it's about using methods like pre-implantation genetic diagnosis, or being able to go through in vitro fertilization and to avoid an abortion issue, but to do embryo selection based on genetic events when there's a high risk of recurrence, like a 50% or 25% risk of recurrence. Those numbers are high to families, and being able to have options for them that don't involve termination of a pregnancy can be quite important. So I say all of this because, again, as you're talking with your patients in terms of trying to decide for whom genetic testing may be more or less valuable, these are the things to consider. So with that, thinking about where is your highest yield? What are the patients that you're seeing where you are most likely to get a genetic answer from currently available tests? And obviously, if there's a very low probability, if there's a 2% probability you're going to come up with a genetic diagnosis, and the family really doesn't see any of those on the previous slides, any of those as utilities, I'm not sure you want to pursue genetic testing. And so I'm not here to be able to say that every single patient should have genetic testing, and obviously you shouldn't force it on anyone who isn't interested in that information. But here are some of the issues to consider. So for many of our patients, and although I'm right now at Boston Children's Hospital, I practiced for 25 years in New York City. So given where you are, I'm going to focus on what many of my patients were like in New York. Based on the patients that we serve, the communities that we serve, we oftentimes have families that may have common ancestry. So whether these are families who may be of Jewish descent, either Sephardic or Ashkenazi descent, they may or may not know of family relationships, but they may have common ancestors that even they don't know about. But that can lead to genetic clustering within certain families where you may have multiple family members who seem to be affected with the same symptoms. It's not just a Jewish thing. There can be individuals from other parts of the world where there are higher rates of either literally marrying other family members. They may be distant cousins. And this can be parts of the Middle East, can be parts of Turkey, can be other parts of the world. But when we see that, and we do see an increased prevalence of that in New York City, having multiple siblings especially, or multiple generations, either for recessive or dominant or X-linked conditions being respectively, can indicate a higher probability of a monogenic condition. When we think about young age of onset, so individuals who may have symptoms, but having them as a newborn, having them within the first year of life, oftentimes suggests that there's a higher probability of genetic loading for those problems. So individuals who may have issues in terms of something like schizophrenia or cognitive decline, but skewed towards an earlier age of onset, tremors, or what may look like, again, what we see in terms of usually adult degenerative conditions, but skewed towards adolescents or young adults. When you, excuse me, when you see those in younger individuals, greater probability that there's something genetic. Excuse me, when you see intellectual disabilities combined with anything else, greater probability, although not certainty, that there's something genetically going on. So as an example, I oftentimes have patients with congenital structural malformations, things like congenital heart disease. When when I see genetics with that, or when I see intellectual disabilities with that, greater probability that that's genetic. In a similar vein, when I see multisystemic disease, or what some people will think of as something being syndromic, so not just affecting the brain and behavior, but maybe affecting growth, for instance, to someone with short stature, in addition to something affecting the brain and behavior, greater probability that there's something genetic. If I see something in terms of muscle weakness and in addition cardiomyopathy, another system, but potentially also representing the muscle, higher probability that there's something genetic. So all of those help you to be able to, again, suggest higher probability. This is what I meant when I was saying familial clustering. So we can see various different patterns, and you're used to seeing this from medical school. There can be autosomal dominant patterns where you see generation after generation. There can be incomplete penetrance where it appears to skip a generation, but in many cases, you will see it in successive generations. In some cases, that family history may not be obvious. Some individuals have migrated from other countries. They may have lost touch with their families. Families may be divorced. Individuals may be adopted. So you don't always have that family history to guide you, but when you do, that can suggest a specific pattern. Recessive conditions, as I suggested, males and females equally affected. You'll oftentimes see a clustering within just one generation. Here, the way I've shown it is it could be generations, multiple generations, but separated by many unaffected individuals. And sometimes you'll get parents saying, oh, but I had that screening when I was pregnant. I had that genetic testing when I was pregnant. There's no way there could be something genetic in my offspring. Just to realize that carrier screening that's often done during pregnancy, or increasingly what is non-invasive prenatal fetal screening, isn't comprehensive, doesn't screen for everything. So that recessive carrier screening that's done often screens for something like 250 conditions, even for the large panels that are done. The things that are done with non-invasive fetal screening are really screening for things like Down syndrome, some of the common large chromosome changes like aneuploidies, but not screening for all things genetic. And so just helping families understand the very limited scope in terms of what's currently done for prenatal screening usually doesn't screen for the types of conditions that you're concerned about. I'll get to it when I come to the end, but even when it comes to newborn screening, really sophisticated parents will say, oh, but my baby was screened as a newborn. They should have screened for everything then. Just to say that even with newborn screening, not everything is included within newborn screening now. So within this, I'm sorry, I should have flipped ahead in advance. These are just the patterns that you can see, as I said, in terms of those. So what are the benefits of doing that genetic testing? As I said, hopefully it's news you can use. That's a catchphrase I like to use. How can you use it? Again, if there's a treatable condition, the thing that greatly pains me, and I have to say it's happened to me more than once, when I identify a treatable condition in a child who's 8, 10, 15 years old, and I realize that the treatment would have been so much more effective if I'd caught this as a newborn or within the first few weeks of life, but where there's been damage done to the brain by missing that diagnosis. And so treatable conditions, if there's any chance of treatment, I actually have a lower threshold to testing. As an example, for some treatable conditions, epilepsy called by glucose transporter deficiency syndromes, very, very treatable with something like a ketogenic diet. Pains me when I make that diagnosis as in an older child, because much of the damage that's been done to the brain by repeated epilepsy, I can't recover, is irreversible in terms of that damage. There are certain cases in which this may be associated with a larger multisystemic syndrome, and people may be only recognizing, for instance, the epilepsy or the hypotonia or the developmental delays, but maybe there are cardiac manifestations. Maybe it is associated with renal disease. Maybe it is associated with longer term cancer risk. And by knowing that and knowing the full picture of what this is associated with, one can get ahead of that and be able to preemptively, hopefully, prevent problems. Again, it can answer some of the questions about guilt and prognosis that we've gone over already. So just very, very fundamentally, and I'll go through this rapidly, the genetic testing that we're doing at this point is sequencing, largely based DNA sequencing. The DNA is obviously translated into proteins for the most part, and being able to predict what those DNA changes are at the protein level is how we do the interpretation of the DNA. We're not perfect in terms of doing this. We don't recognize everything in this. And in many cases, very subtle changes in the proteins, we're not able to predict whether they're deleterious or cause disease or not. I'll get into that in more detail. But within all of these, we're reading out largely the germline and trying to understand how that affects long-term, how the body is functioning. So there are a couple different ways that you may think of as in testing. I'll say very briefly, there's what I call targeted testing. That's focused on particularly the phenotype or the symptoms that the patient presents with. We currently have in the laboratory set up panels of genes that fit with that indication. So what I mean by that is you don't have to know all of the details of what genes cause epilepsy, what genes cause autism, what genes cause muscular dystrophy. You can simply have a requisition and literally check off muscular dystrophy. We on the laboratory side are keeping up to date, I hope, in terms of all the genes that do cause those conditions and being able to match what you're seeing in the patient. So that's what I mean by panel genes. In that case, we're testing the child's only. It's very narrow in focus. If you're wrong about the phenotype or the clinical symptoms that you're seeing, you're going to get testing for the wrong set of genes. And over time, there may be new genes identified that will not have been included in the panel. And of course, you get at that time frame what genes are included. Some panels will be 10 genes, some panels will be and can be even a couple hundred genes, so they can be quite large and inclusive. Many times you'll get, as I'll be explaining, variants of uncertain significance from panels, and that's in part because you're testing only the child. So there are some virtues, believe it or not, in terms of doing larger tests or more comprehensive tests. One gene or one condition specifically is Fragile X, which is hard to test by either panels or things like exome sequencing, which I'll get to. So if you have a strong suspicion based on the family history of Fragile X, order a very targeted Fragile X test. And then finally, chromosome microarray is a genomic test in the sense that it looks across the genome, but it's looking for relatively large genetic changes, be they deletions or duplications. By large, I mean simply real estate. So if we were to think about, the land mass on the face of the Earth, a chromosome microarray will be detecting things that, for instance, might be the size of Rhode Island or larger in terms of land mass. They're not going to pick something as small as the address of 300 Longwood. That resolution, that detail is not visible on something like a chromosome microarray, but it will test around the world any land masses that are greater than, as I said, something about the state of Rhode Island. There are certain cases, and now I'm on the right side of this, where you're doing a single site or single gene. So if you know about a condition specifically within the family, you know that the family has a history of muscular dystrophy due to DMD, Duchenne muscular dystrophy, you only have to test that one gene. Don't waste resources. Don't run the risk of looking for the wrong mutation. Tell the laboratory the mutation in that family, and then you get a very clean answer, yay, nay, yes, no, if you know the mutation in that family and can go forward in terms of treatment for that condition. Within this, I will say that I also think about reflex testing or tiered testing. So that, for instance, if you start with a targeted panel and you don't get an answer, but you have a very strong suspicion that there's something genetic based on the family history, you are allowed to and should consider going from a targeted test and sort of ramping up to a genomic test like whole exome sequencing or whole genome sequencing. So what is exome sequencing? It is not comprehensive, but it does include about 2% of the genetic information of the genome. It is targeted on the regions of the genome that encode the protein. And so each of these come in little tidbits called exons, EXONS. Those are the coding regions. And if you put those together in the aggregate, we call that the exome. As I said, this is about 2% of the information. It's efficient to be able to look at only this and interpret only this because we simply have, about, 2 orders of magnitude less work to do. In doing this, it is helpful to get the parents in this analysis, and I call this a trio, meaning mother, father, and child with the condition. The reason for this is if I were to take your DNA and read out the genome or even the exome in terms of doing this, depending on what part of the world you're from, I would likely end up with tens of thousands of genetic variants that I don't know how to interpret. That's how early we are in terms of the understanding. And to be able to help me narrow down the search space, the parents are very helpful. The parents are helpful in the sense that I can very quickly filter out de novo genetic events in the child, things that are new in the child and not present in either one of the parents. That's a very simple experiment. And I go from having tens of thousands of genetic variants to potentially 1 or 2 or 3 per child of de novo coding variants. And so computationally, sort of cognitively, that task becomes much, much easier. And I am less likely to make a mistake and miss a diagnosis if I have the benefit of the parents. And so I will, and it costs from the laboratory charge point of view, costs no more for the laboratories usually to run the the trio as opposed to just the child or the individual with the symptoms. So very helpful to do. In some cases, it may not be the parents and the child, but if you have multiple siblings who are affected, you may do the exome, taking all of your affected individuals and running them in the laboratory and looking for things that are shared variants across the affected family members. That's another good way to winnow down the search space. So in doing so, and just as some practical tidbits, in doing this test, most laboratories now are able to do this on blood or even a cheek swab. So if you look at CSI or any of those television shows, relatively simple, non-invasive to do. Even I can say I arrange testing done at home. So if you want to set up and implement a sort of clinical care system where you're doing even video medicine or video visits, it is even possible to do this remotely if you think that parents and families can do the sample collection at home. Let me set some expectations. What's the diagnostic yield? What's the likelihood that you'll come up with a diagnosis if you do something like this for a child with or adult, but individual with intellectual disabilities and autism? So those two together, more than a quarter of the time, you should get a diagnosis from something like exome sequencing if you do that as a trio. The limitations of exome sequencing are that it's not perfect. It's a sequencing-based test. It still misses things that are, for instance, those triplet repeats like Fragile X, it will not pick up. So you do need to order Fragile X separately, and relatively modest size deletions or duplications, it may not pick up. So in general, if you're really concerned, I do a chromosome microarray in addition to the exome sequencing. The two of those together, oftentimes very useful and comprehensive. I will warn you, though, there is one thing that many neurologists don't feel comfortable in terms of ordering exomes or genomes, is that because you're sequencing everything, we don't see just what might be the cause of, for instance, autism or intellectual disabilities, but we can also see everything in the genome, and that may include things like BRCA1 or 2, a risk to hereditary breast or ovarian cancer that may have significant health implications for a child or their parents. And so there is this so-called incidental findings. We incidentally see these things. It's not the primary reason we're running the test, but it is important to tell parents about this or individuals about this so they can decide whether or not they want to do this. They don't have to have this information, but it is something that they might find beneficial, and it's just better to tell them in advance. Okay, so we get a report. How do we actually understand what these reports mean? As we're doing these sequences or copy number variants, we see a genetic variance, and the laboratory needs to classify these into, is this something benign, something that we see with many, many different people, a so-called polymorphism seen in up to 1% or more of the population, or even if it's rare, still benign, or is it actually disease associated? One of the terms we'll use is pathogenic, meaning that it's disease associated. So here's the classification system. I'm showing you under the hood what the laboratories do. And there are 5 different categories based on the current, what pathologists and geneticists have accepted in terms of guidelines for classification. A variant will be classified as either at the one extreme benign or the other extreme pathogenic, and within the middle, degrees of uncertainty about either of those. Something that's likely benign or benign, I can tell you really seriously don't worry about. It really is likely to be a normal variant. Pathogenic, we assume, is close to 100% likelihood that it's disease associated. We're fairly certain of that. Likely pathogenic, just to put a quantifiable number on it, we're about 90% certain that it actually is disease associated. And from a clinical care point of view, if something is classified as pathogenic or likely pathogenic, it is accepted that clinically we will act on that as if it's a diagnosis. It is important for you as the clinician, as you get that report back that says it's likely pathogenic, do the sanity check. Make sure it makes sense to you that that's the diagnosis that fits. Look clinically at those characteristics, see if it matches your patient. If it doesn't match, push back on the laboratory. Remember that number is 90%, it's not 100%. The laboratory has not seen your patient. They're going by what you put on that test requisition. It's important for you to be as complete as possible so they can do the best job of interpretation. But sometimes the information they've received from you is very nonspecific. If the only feature you give is intellectual disability or autism, there's a very wide spectrum when it comes to autism. And when they come back with a diagnosis that suggests that this person should also have polydactyly and your patient doesn't have 6 fingers or toes, push back. Think back whether or not that makes sense. Do the sanity check. The bugaboo is variants of uncertain significance, and those variants of uncertain significance really truly are uncertain. But again, to give you quantification on this, right now, 90% of variants of uncertain significance over time with additional data will be reclassified as likely benign. So in contrast to likely pathogenic, most of the ones that are uncertain are not your answer. So do not act on those clinically as if they're the answer. You definitely need to take the information from those, do the sanity check, understand whether you do the judgment and decide whether or not that in fact is likely to be disease associated. So with this, I consider this an iterative process. Do not take as the final, when the laboratory gives you the report, sort of the truth with a capital T about what the answer is. Take that and then do the assessment in the context of your patient. Does that make sense? And then you be the judge. You are going to be the one making that final diagnosis about whether that makes sense. If you feel that you don't have the knowledge to be able to make that final interpretation, that's when you phone a friend. So you phone a friend, and I get phoned all the time, although it's usually email these days, in terms of people who say, I don't know enough about this condition. I will tell you, I have friends from around the world who do this, many of whom are geneticists as well as non-geneticists, and they call me because I have expertise in that particular condition, and I know that incredibly well. And so it's okay to phone a friend. That should not be seen as any sign of weakness or you're not clinically qualified, because these are very, very rare conditions and none of us know everything. So do that in terms of final adjudication and making the final decision. And you may even have to bring your patient back into the office to look for specific features that you didn't look for before, or you may need to do an echocardiogram, or you may need to do a particular laboratory test to see if their liver functions are normal, because maybe you can't tell that until you do that test, and that's okay until you make that final decision. So let me just guide you through orientation of the anatomy of a laboratory test. I happen to take a report from GeneDx. There are other good laboratories, so I'm not saying GeneDx is the only good laboratory, although I do think they are a good laboratory. As you'll see in terms of looking at this, we and others have actually built criteria for standard ways to have what I think of as an executive summary for what's on that test report. And the bottom line is we have come to consensus to try and make this easy and consistent for you, that there will be this executive summary of the bottom line when you're really busy and you're flipping through a million things coming into your in basket. The bottom line is, look at this result and positive. What does positive mean? Patients always ask me this. Positive, is this good news? And positive, what this is meant to mean is positive that there is a diagnosis, right? And so whether or not you want to, from a personal point of view, interpret that as positive or negative, that's up to you. But positive means there's a diagnosis. Within this, below this will then come the details of what that actually is. The gene is here, GRIN2B. It's associated with this condition, very originally named GRIN2B related disorder. It's autosomal dominantly inherited. This is a de novo variant. And in the classification scheme that I just discussed, it is a pathogenic variant. So the laboratory is telling you, in our opinion, we are very certain that this is the answer. With the clinical information you have provided, and they're putting it in this box here, that's what their assumption is in terms of the clinical context. They think GRIN2B makes sense and explains the symptoms for these symptoms that you provided. Okay, so within this, this has implications both for the patient in terms of explaining their symptoms, and remember, it also affects the family. For a de novo genetic variant, there is about a 1% chance for parents that it will happen again. And that, just as a fun fact that you'll learn today, the reason why that can happen again is that some parents will actually be gonadal mosaics. These are fathers in particular. It doesn't happen very often, but where a father will have sperm that will have that particular mutation, and simply by doing the blood test or the cheek swab, you won't detect it. You'll only detect it by doing a sperm analysis. And just PS, that actually can be done clinically these days for people who are interested in it. Again, this has implications potentially for other family members, other more extended family members, siblings who also are worried about their risk of recurrence, or families, if their parents, rather, if they're still having other children. The problem with variants of uncertain significance is that you're in purgatory. I think of it, genetic purgatory. If you get a variant of uncertain significance from panel gene testing, my advice, if you ever email me, is always test the parents. Go back and test the parents specifically for that variant of uncertain significance. If you see that an unaffected parent has that same variant, it is unlikely to be your answer. On the other hand, if you identify that that is a de novo variant in the child, much more likely to be the answer. not definitive, but again, probability, trying to determine that. In the laboratory, some laboratories will do parental testing for free, some not. All I can say is you have to check with your individual laboratory, and policies and times are changing. So that's a little bit hard to know. If you don't have final adjudication, there is a resource that is free that we all as good citizens populate called ClinVar. You can Google it, but ClinVar is a resource where we try and put de-identified information about variants and their interpretation, and many laboratories will populate that so that if you have a patient and you're seeing them and follow up a year later, and that variant was last classified as of uncertain significance, and you want to know, is there any new information, you can go into ClinVar and see whether there's an update and if other laboratories have seen that same variant and what they think about it. For exomes, there are many of the laboratories, that over time will actually reanalyze your information. We'll go back to it and give you an update on that. Sometimes the laboratory will do it every year if you wanted to. Sometimes they'll do it one time for you. Again, check with your laboratory, and that may influence which laboratory you use. So as I said, in doing this, if you get stuck and you feel like you can't interpret it, you can't arrange for family member testing, you can't do, like, it's sort of above your pay grade, do feel free to phone a friend, and your local geneticist will be glad to help you with those things. Okay, within this, as I said, for exomes in particular, there's even more reason to go back and look back and do reanalysis, and that's because we're learning more over time. We're identifying new genes for these conditions, as I'll be showing you. And so something that was sitting there but not recognized to be the diagnosis oftentimes won't be recognizable 6 months later, but if you look 6 years later, it may very well be recognizable. And so many of us do this with some fair frequency. Your laboratory will not do it automatically, but they will do it if you poke them oftentimes. So again, if there's something that comes up, something for the family, a change in clinical situation, change in family planning, mom's now pregnant and wasn't expected to be, things like that may trigger you to do a reanalysis. The probability of reanalysis, just to give you a number on this, can be as high depending on the interval between testing at baseline and reanalysis, pretty significant, again, for well-selected cases. So I don't think it's an exercise in futility, but again, it's the well-selected cases. That's on you to decide, is this, again, going back to what I said earlier, a child that likely has a monogenic condition. Just to say, and this is from some of my own work on autism, de novo genetic variants are relatively easy for us to recognize. This is from a paper we published last year on autism genetics, and what I'm showing you is the same genes in red on the right have de novo genetic events, but some of those same genes, KDM5B, GIGIF1, NAV3, ITSN1, we're now realizing have inherited variants as well. And I will say those inherited variants are harder for us to recognize if you don't correctly identify the parent as affected. And in some cases, the parent may not have autism specifically, they may have other related behavioral conditions. And so it becomes important to take a family history, report that family history so that we correctly interpret that data for you. Autism, I'll just spend 2 seconds on it, is especially difficult because what I'm showing you on the left are, I think of these as different effect sizes. So on the left are some of these de novo genetic events that have very, very strong effect sizes. They increase the probability of autism by 100-fold. They really are, some people ask me, is this the answer in terms of the diagnosis for autism? And for simplistically, I will say yes, it usually is the answer in the sense that the effect size is so large. There are other of these inherited events that I described that are much smaller effect size. Those are in the middle, and some that are very common with small effect sizes. I'm going to go relatively quickly through some of these because these are more sort of researchy types of things, but to say that some of these conditions from SPARK, Simons Foundation Powering Autism Research for Knowledge, a research study that I do that you can Google that and see that online. Many of these genetic events we're realizing are not just related to autism in parents, but related other things, learning disabilities, social anxiety, schizophrenia, other more mild cognitive impairments. So they are related to other brain and behavioral conditions. Some of these conditions we've realized that by looking at them over the life course are not only associated with autism, neurodevelopmental issues, but are actually neurodegenerative. So this one condition that I described, something that's called Jordan syndrome due to mutations in PPP2R5D, once we started looking at it over the life course associated with macrocephaly, autism, sometimes epilepsy, neurodevelopmental disabilities in children, start to be associated with tremulousness, even in adolescence and young adulthood, with individuals that die of Parkinsonism, oftentimes in their 50s, with neurodegeneration that we can see pathologically, also loss of cells in the substantia nigra, and also responsive in terms of dopa drugs that we use. And so the good thing is, although it's bad news, it's some good news in the sense of treatment that are available. And even with what we hope to be starting in a few months, clinical trials in terms of being able to treat these conditions. In some cases, as I said, this is another condition we study, PHIP, knowing that over the life course associated with obesity, especially in adolescents and young adults, actually ends up being a significant health risk, one we try and get ahead of in terms of physical activity, dietary intervention, and now even treatment with a medication called setmelanotide, which looks like it has very specific targeted effects for this gene across all genes associated with obesity. So increasingly this precision medicine that we think of. And finally, another condition, KIF1A, associated with KIF1A associated neurological disorder. Again, you can see here the degeneration. This is the bad news associated, if you look at the cerebellum in particular, over even just a 2-year period, the rapid degeneration that we can see. But some hope, I want to say, that based on my first N of 1 study with an ASO targeted at specific allelic specific knockdown, you can see over time on the x-axis and over seizure frequency, length of seizures, or fall with this, what's associated with spastic paraplegia, the improvements that we've seen, again, very, very early days, but in this N of 1 clinical study to be able to assess outcomes. So again, increasingly important to have a diagnosis to drive what are sometimes experimental treatments, but hopefully ultimately things that are FDA and EMA approved treatments. And this is just simply with the KIF1A study showing a decrease in the spike wave index also over time with this, again, experimental treatment. So just to summarize in terms of the pros and cons, in terms of thinking about genetic testing, you can go from something that's quite sort of gross in terms of a karyotype that will tell you very sort of large genetic events like Down syndrome to things that are very, very finely detailed in terms of exome sequencing, getting higher and higher resolution. Hopefully you've had some sense of the utility of that and how to interpret that. I will make the final point that insurance is covering, if not all of these tests, most of these tests. And that is true of Medicaid patients, private insurance patients. The only patients where I sometimes have difficulty is with Medicare, but with Medicaid and children's coverage, it has gotten increasingly covered. And we've had many, many campaigns with state and federal funding agencies in terms of coverage. And in New York, you're doing pretty well. So just to summarize, start the testing whenever possible with the affected individual. And one other thing for me to mention is that turnaround time is often slower than a CBC, as an example. So turnaround time is oftentimes measured in weeks to months, those weeks to months being oftentimes 4 weeks to something like 3 or 4 months. There is opportunity for inpatients, and I don't know how your hospital is set up, but there is opportunities for rapid turnaround time, what I call stat testing, with results less than oftentimes 5 to 7 days, even for exome sequencing, which increasingly are used, for instance, with things like new onset seizure in young children to be able to get those under control. I'll let you decide how your healthcare system is set up for that. We also are trying to have clinical care guidelines for many of these conditions, even the rare conditions. I'll just point out that Gene Reviews is a free open access place where many of us in the community write to be able to have in a standardized way when you're in a busy clinic, easy bulleted ways of being able to read about a condition. It's sort of up to date, 2 minutes or less in terms of skimming through this, understanding how to test, what to do for this, how to recognize it. And if you had one go-to resource, I'd say that's one of your best resources to use. It doesn't yet have all 7,000 rare diseases, but for many of the common or more common genetic conditions, there should be something there. Are there reasons not to do it, or what are the things to be wary of? If you get a negative genetic test, that is not a guarantee that is not genetic. So I just want to underscore that one more time. We don't know everything. We don't recognize everything. It doesn't guarantee it's not genetic. When it's positive, though, then it gives you increasing utility. It also, though, a negative test does rule out some of the things that you might be concerned about, and increasingly it rules out the things that are news you can use, treatments that are available. Again, not 100%, but it does help you in terms of how hard to push for the things that are treatable. It sometimes can be distressing, especially for parents of young children, where they might not have realized the prognosis was as serious as it is when you come up with these diagnoses. So you have to warn parents that it is possible that you'll get new prognostic information that may be distressing. And some parents don't want to know about it, or may not want to know about it at that time. They may want to wait a little bit of time in adjusting to that diagnosis. So I'm not saying it's for everyone in terms of going forward. Let me just, in the last couple minutes, and I'll save time for questions, point out something that is the new emerging space, specifically in New York City, which is a study I've been leading in New York called Guardian, Genomic Uniform Screening Against Rare Diseases in All Newborns. This is based on newborn screening, meaning that we take the same dried blood spot that we use for newborn screening and on newborns in an attempt to be equitable. And that's why I say in all newborns. It really is meant to be all newborns. We try and be equitable with access to genetic testing for news we can use, for conditions specifically where we think we have an intervention specifically that affects young children that we've defined with age less than 5, with treatments that are available, and with a high probability of the information we're returning back being a true positive. But this is tricky because it is predictive testing, given that newborns generally are not symptomatic, and we have to have a single pipeline with treating every single baby the same way. It is a consented research study, meaning it is free, but it does require consent. It does not happen automatically unless parents agree to do this. We have selected a set of conditions, and we now are running about 500 conditions, which again, age of onset is less than 5, high probability of actually having symptoms, that is high penetrance. This is a little dated because just a couple weeks ago, we were only running what I call version 1 of the test, which had about 250 conditions. But this is divided for your purposes into group 1, which is treatments that immediately, I would dare say, are, if not curative, very, very effective in terms of treatment, but also at parents' request include 100 conditions associated with epilepsy or with neurological conditions, because we believe the epilepsy to be treatable, and so wanting to give parents that option. All parents or all children in Guardian get group 1, and group 2 is considered optional, but approximately 92% of parents who decide to do the study also do group 2 as we're doing it. This is to give you a sense. In the first 7,700 patients that we've screened in New York City, most of the positive results are coming from group 1, but we do have a fair number of patients coming from group 2 within this. And again, this is out of 7,700. We have about 3% of babies who screen positive, to show you that beyond the screening test, because this is just a screening test, we continue to follow the babies to determine which of those are true positives by doing more definitive diagnostic testing. In the screening test, we only test the baby. When we do the definitive test, we include the parents. We do additional orthogonal testing, which will turn some of those into true positives, some into false positives, and some where we still don't know. The children aren't old enough yet to demonstrate manifestations, so we can't make a final adjudication. Focus on the group 2, because those are, again, the neurogenetic conditions associated with epilepsy. About a third of those I can say are absolutely true positives. About half are false positives, importantly, but we can tell parents after a couple weeks when we get the final testing that those in fact are false positives and let them go. And a few of them where we're continuing to monitor those babies very carefully. Just to give you one example, we had a child that came in with a Rett-like syndrome mutation, CDKL5. When we tested the parents in the second part after getting the screening results, we found out this was de novo. And within the first few weeks of life, the baby actually did have her first seizure, was treated initially before we had all of the information together with one medication, and then subsequently refinement of her treatment, and is also now, knowing that this is associated also with developmental delay, plugged into early intervention, and very clear in terms of being able to have information going forward and information for families because they still are planning on having additional children. So this type of information, the main point I want to make is I think it's very helpful in terms of equity and being able to improve access. And we're currently doing this through the New York Presbyterian Hospital Associated hospitals and through their delivery program, so the newborn nurseries for those babies born there. So just finally to say, and the take-home message in terms of genetic testing is accessible, it's covered by insurance, it can be helpful, I hope increasingly in treatment, but certainly always a choice both for you and for the families. So let me stop there and I'll be happy to take questions.
Thank you so much, Dr. Chung, for the comprehensive talk. It was very helpful. Thank you. Let me see. We have questions in the chat. Ahmed Siddiq, one of the neurology residents, has questioned, if genetic screening for the affected child is not available for some reason, is screening their siblings or parents alone will be helpful?
Yep. So the circumstance where this has come up for me most often is the case when an affected child is deceased, and so they're no longer available for testing. If the unaffected sibling is usually not helpful. In certain cases, I will, out of desperation, run genetic sequencing on the parents with the hope that I might identify a recessive or inherited genetic event. And I have in some cases made that diagnosis. It is more likely than not that you will not make the diagnosis. There are ways of being able to, and I am more likely to do this, I call it dumpster diving, but looking for any DNA source that might be available from the affected child. Sometimes I actually go back to an archived newborn screening blood spot to be able to get some source of DNA from that affected child. I have been successful in those cases. I have oftentimes identified a diagnosis in what I call a molecular autopsy, being able to go back. The main problem with that is the insurance issue. Insurance will not cover oftentimes the deceased individual, and so the family sometimes has had to pay out of pocket for that. So it gets to be a little tricky, and bringing in your genetic colleagues can sometimes get you through some of those tricky situations.
Yes,
I see a question.
Yeah, there is one question in the chat. I can go ahead. From Dr. Guten. I always use NVT panel for epilepsy. Would you recommend anything in addition or instead of which may be better? Should be tailored based on suspected condition?
Yeah. So in general, panel testing for epilepsy tends to be very good in the sense that the laboratories have been good about keeping up, being comprehensive in terms of those panels. The biggest problem I often see is that if they're very comprehensive, you may have a higher probability of the variants of uncertain significance. Invitae at least used to have a policy where they would do free parental testing to try and adjudicate those. I will say just follow closely. Invitae has recently filed for bankruptcy. They're still open though and performing testing, but whether or not, and I haven't kept up like literally moment to moment, whether they're cutting back on services and sort of other benefits in terms of cost savings to stay in business, just watch that carefully and check in to see what they'll do. But there are several laboratories that I think have good panels, and epilepsy is a good way because in part you get results back faster. And especially if you need to have for new onset epilepsy information quickly, that some laboratories even have a stat epilepsy panel to be able to get results in a targeted way very quickly.
Thank you. I have one question. If you have a family come in and the parents clearly have some type of genetic thing going on, but they don't have,
Can you get closer to the mic?
Yes. Can you hear me better now?
Yes.
Okay. If you have a family come in that looks like the parents have some type of genetic condition, if you don't have obviously their own parents, do you ever consider testing the children if the children at that time don't have any symptoms?
Yep. So I'll repeat the question. So if there's a family history or parents with a condition and the children are asymptomatic, in general, there's an ethical principle also to keep in mind, which is if you're talking about things like Huntington's disease, Alzheimer's, Parkinson's, things that won't affect the children until they're over the age of majority. And if there's nothing you would clinically do differently in terms of managing them, I do not test the children for those conditions. There's a concept that we think of as the right to the open future. So the child is the individual. They really own their own information and should make their decisions for themselves. So that is a guiding principle, is one that I consider. There is theoretically the possibility in terms of maybe there is a treatment, maybe there's something that it would be done to prevent progression or prevent the disease. That would be a different circumstance, and from an ethical point of view would be obvious to do. I do try and engage adolescents, for instance, in those decisions when they're cognitively capable of doing that. But you always want to test an affected person first in the family whenever possible, so that you know you're testing the right gene and correctly interpreting the variant. So if parents are available, as long as they're not deceased or estranged from the family or adopted, I would always suggest testing the parents in those situations first. And they really, if they want to test the children, they should be wanting to test themselves, because they're trying to do the best that they can for their kids. So the only circumstance I've run into are, as I said, where the individual's adopted, but there's some known family history.
Thank you. I have one more question.
Sure.
I just wanted to talk more about some of the related conditions you said to autism.
Can you try again? You're just a little fuzzy.
So yeah, so what the question that we were discussing is about the related condition with autism. For example, if a patient comes and we did the autism ASD panel or NDD panel, and we'll get variants of unknown significance, and the family member accompanying the patient may have some kind of like neurological conditions, or maybe as simple as ADHD. Would that be considered as a related disorder?
Yes, I'd consider that sort of all bundled under the brain and behavior.
Yes. Sounds good. And in that case, we would take that variance of unknown significance as clinically significant.
Yes.
Okay, got it. Thank you. Dr. Chung.
Okay, I'm afraid I've got to drop off for another meeting, but it's been very good to see you.
Thank you so much, Dr. Chung. Have a
Bye-bye.
great day and have a great weekend, everyone.
Bye-bye.